Hello and welcome to the European Respiratory Journal podcast. My name is James Chalmers and I'm the Chief Editor of the European Respiratory Journal, and I'm delighted to welcome you to this podcast. We're going to be talking COPD today, and I'm delighted to welcome Dave Singh. I'll ask Dave to introduce himself in a moment. And we're going to be talking about an important paper that's published this month in the journal from the Gold Scientific Committee talking about pre- and post-bronchodilator spirometry in people with COPD. Welcome, Dave.
Hi, James. Good to discuss this with you today. So I work at the University of Manchester. I'm a professor of respiratory medicine and clinical pharmacology.
Dave's also a member of the Scientific Committee of Gold and is the first author on this publication. So Dave, why don't you summarize it for us? What's the latest recommendations for Gold around pre- and post-bronchodilator spirometry?
Yeah, I will summarize it, but it might be useful for the listeners to have a little bit of background into why we actually conducted this piece of work, because the use of post-bronchodilator spirometry for diagnostic purposes has been there in clinical practice for decades. And one of the Gold Scientific meetings, we meet twice a year, one of the members raised, is there still good evidence for doing this? Is it still the best way to diagnose COPD? And that's when I put my hand up and said, well, I'll go and do a literature review. And I brought that back and we went through it all. And the reason I say all this is if you read the paper, we didn't start with the position to justify using post-bronchodilator. We actually went into it with a fresh pair of eyes to say, is this the best way to do it? And the discrete question was, what's the value of using pre-bronchodilator versus post-bronchodilator? So the take-home message. I think in clinical practice, there has been a tendency just to go straight for the post-bronchodilator value and ignore the information that the pre is giving you. So that's really the message of the paper. Look at the pre-bronchodilator value. Does it tell you something? And using the fixed ratio, you'll save yourself some time, because you will find that there are a number of patients whose fixed ratio FEV1 over FVC is well above 0.7. And then you can rule out the diagnosis of COPD and you don't need to go to the post-bronchodilator value. I should caveat all this by saying that you, of course, will be using the clinical information alongside. So it's the exposure, smoking history, and the symptoms. So spirometry is part of that diagnostic process. So you've done the pre-bronchodilator, you've ruled out a number of cases. I think that's the big change that we're introducing. If the ratio is less than 0.7, we still recommend that you go on and do the post-bronchodilator to confirm the diagnosis. So that's the simplicity. There are some nuances in there. First of all, the pre-bronchodilator, there are some patients who will be close to the 0.7 and they'll be highly symptomatic, and you still suspect that they've got COPD. And they might have what we call a volume response. So obviously the FEV1 over FVC is a fraction, and COPD patients who have lots of gas trapping, once you give them a bronchodilator, they'll have a volume response. So these patients will tend to be more breathless. They'll tend to have a lower FEV1 anyway, and the ratio might be close to that 0.7. Now, in those cases, in the document we write, you've got a high suspicion that they could be a volume responder. Go on and do the post-bronchodilator, because you might find the ratio drops. So that's one nuance. And another nuance is the post-bronchodilator. What happens if somebody had a ratio less than 0.7, you did the post-bronchodilator, and then it increases? You need to keep a close eye on those patients. So looking at the cohort studies, about half of them go on to develop clear COPD on spirometry, pre-bronchodilator and post-bronchodilator is less than 0.7 over the next few years. So I hope that is a reasonable summary of the top points.
Yeah, I think that's a great summary, and it's nicely summarized in the paper as well, particularly in figure 3, which summarizes exactly what Dave said. And an important message, I think, that post-bronchodilator spirometry, if it normalizes, that doesn't mean that the patient doesn't have a problem, because if they've presented with symptoms, they do need follow-up and further investigation. This has been a controversy for a number of years, Dave, but why does GOLD use the fixed ratio of 0.7 rather than the lower limit of normal? We get lots of papers coming into the journal on both sides of this argument, so it'd be nice to hear the GOLD position on this.
Yeah, it is a controversial area, and we sort of ducked it in the paper, actually, because in the introduction, we said we're going to focus mainly on pre versus post, because this topic deserves a paper all on its own. But I'll give you our views, because actually in the updated GOLD report, we do give some further information on that. So it's not actually in the paper. So the lower limit of normal is not diagnosing disease. It's telling you, are you at the extremes of lung function? And I mentioned earlier that to diagnose COPD, you need the clinical information plus a lung function test. So the fixed ratio of 0.7 has served well over the years in conjunction with that clinical information. The question is, if we switched over to the lower limit of normal, would it work better? And there isn't any evidence that it would work better. So that's one of the problems. Do we just change for change's sake? Are we actually making an improvement? There are arguments for and against using the lower limit of normal versus the fixed ratio. So we recognize that the fixed ratio will underdiagnose in younger people, overdiagnose in people who are older, but that's only if you are using lung function on its own. So if you add in all the clinical information, and then for people who have results that you think are wrong, that's where using additional information, such as the lower limit of normal, such as other clinical tests you might have available, might help you. So this isn't black and white. There's a couple of technical points then to raise. One would be that the lower limit of normal values are all pre-bronchodilator. And there's a nice paper in the Blue Journal showing what happens to the diagnostic process for COPD if you have a post-bronchodilator lower limit of normal range, and the number of diagnoses fall, which is exactly what happens if you use 0.7 as well. As soon as you switch to the post-bronchodilator value, the numbers of diagnoses fall. So that's a technical problem to overcome. And the other issue would be that this has to be global, and the lower limit of normal values are not quite there for every single country. So there's that side of things. It's a complicated situation. And as I said earlier, I don't think it's black and white. In the end, if we were going to make a change, it had to be implementable, simple, and an improvement. And I don't think we're there for that.
I think it's a clear message that we need something simple that people can use in multiple situations. And currently the ratio is quite well understood, and none of these things are perfect. On the topic of none of these things being perfect, the 2025 report recommends that if the post-bronchodilator ratio is between 0.6 and 0.8, that there should be repeat spirometry because of the potential that you may miss or overdiagnose COPD. I wondered if you wanted to comment on that, because I think it feeds into this idea that spirometry is a very useful test, but needs to be taken in the context of the symptoms and the natural biological variation in this test.
Yeah, absolutely. When we wrote that sentence, it really alluded to the fact that you had to use all the information you have. So we're not saying that if somebody has a test of 0.65, you blindly repeat it. For example, if you have a younger person and they have a high symptom burden and you do the test and it's 0.65 and their CT scan shows emphysema, I don't think you have to go any further. But if you have an older person who barely has any symptoms and they have a ratio of 0.65 and the Z scores would indicate that that's within normal for that individual and the CT scan is normal, that's a different clinical picture. So we're advocating that you repeat it where when you put everything together, you think that the spirometry, because of day-to-day variation, because of different flow and volume responses on that day, isn't giving the correct diagnosis that fits all the other tests.
So Look into your crystal ball for us, Dave, and let's think about where diagnosis of COPD is going. I think there is a push towards diagnosing COPD earlier and intervening earlier before people have fixed airflow obstruction. Do you see that the way that we diagnose this is evolving, and maybe we'll be using more sensitive lung function techniques or CT? Or do you see that spirometry for the foreseeable future is the only way for us to do this? What do you think Gold 2030 is likely to be saying around COPD diagnostics?
Yeah, I hope you won't hold me to this.
No, there's only thousands of people listening, Dave. So.
On the face of it, I guess that the paper we've just written might seem slightly non-progressive. In the current era where we are looking, as you say, and novel lung function tests and imaging, etc. We've written a paper which says, let's stick to what we've always done, but with a refinement to make it more scientific and more practical and less time consuming. That's on the basis of the fact that we need to diagnose this worldwide and we need a simple first way of doing it. So in 2030, I still think this will hold as a simple way of doing it across the world. What I would hope to see, looking into my crystal ball, is that specialists have now at their fingertips other ways to diagnose the earlier stages that may or may not meet these spirometric criteria. So that won't be primary care based necessarily. So we might be looking at oscillometry or other lung function tests or imaging. We now have lung cancer screening available where we can very quickly get information on people. So I think there will be, in some countries, an avalanche of imaging abnormalities, which mean that people have to be kept under close surveillance. So I think that will be a situation in 2030. And for a number of years, they may not meet these diagnostic criteria, but their disease may be progressing. And that's where we will need other tests and what we call them in future. At the moment, we have phrases like pre-COPD. Some of them who maybe, say, have a high BMI might then have a lower FVC, and we call them PRISM. But these people don't fit into clinical trials at the moment. We don't have an evidence base for treatment. So I think that's the growing area.
That's terrific, Dave. Really great to get your perspective on this. This paper, I think, is really important. I think you've explained why. Although it's lovely to think about new technologies and what's coming in the future, at the moment, the day-to-day work of many respiratory specialists is spirometry and diagnosing COPD. And this is a practical document that's going to save people time and clear up some confusion. So I think it's really, really useful. And we're delighted to have published it in the ERJ. So thank you, Dave. Thanks for joining us this month to talk about it. The paper's online now. And please join us again next month when we'll select another paper from the European Respiratory Journal to discuss. So many thanks for joining us. Goodbye.